Well, since it's 10:05, I suppose we can just go ahead and get started. So usually I do the introducing, and then I realized on my way in today that I was also doing the presenting. So I was like, I probably should have figured this out, but I suppose I'm going to do a little bit introducing of myself and also Courtney, of course. So today Courtney and I are going to be presenting on the relationship between the self and the world in psychotherapy for psychosis, and offering some contributions from the metacognitive approach. I am, for those of you who maybe don't know me, I am a clinical psychologist at Sandra Eskenazi in Indianapolis. And Courtney is a clinical psychologist at the Austin VA Clinic in Austin, Texas. So that's a little bit about us before we get started. All right, let's see if I can get these to advance. Okay. So today we will start out briefly discussing and offering some background on the concept of centrality and what that is. We will then discuss how the understanding of centrality and the integrated metacognitive model kind of merge together to guide recovery-oriented psychotherapy practice. And then next we will consider how centrality can be operationalized and measured as a feature of metacognition, specifically through the domain of decentration. And then through this lens, we'll then propose a three-stage approach to addressing centrality within integrative metacognitively oriented psychotherapy. And specifically, we're going to use examples from Merit, since this is what we both practice. And then finally, we will share just some thoughts about potential future directions of this work. And I guess I should have said before that we will have probably around a half an hour at the end for just discussion and questions and things like that. But if any questions come up as we talk through some of these things, feel free to jump in or raise your hand or whatever you need to do. And we're happy to discuss throughout the presentation as well. All right. So since its early descriptions, recovery from psychosis has involved, both objective, easily measurable outcomes of recovery, as well as subjective processes that are not necessarily reducible to symptoms or skill deficits, such as quality of life or connectedness. But despite this, traditional approaches to therapy for individuals with psychosis sort of tend to target symptoms or discrete skill deficits, which seems to neglect these more important subjective aspects of recovery. So it doesn't really kind of address all of the challenges or capture all of the challenges that individuals with psychosis are experiencing. And so one reason that there's tended to be a lack of focus on these on interventions that are targeting subjective experience in psychosis is due to the challenging nature of defining and quantifying such a complex, uniquely individual concept. And so as such, subjective experience seems to really require a different kind of approach that allows for flexibility and emphasizes personal meaning making. And so one way to conceptualize the subjective experience of psychosis can be found in Henry Grivois' work, in which he suggested that psychosis involves the subjective experience of oneself as sort of the center or focal point of the world. And this is an idea that he termed centrality. And he described this experience as a core feature of psychosis, in which the world that is typically unrelated to oneself becomes incomprehensible and is replaced with this sense of that all life events are directly related to oneself, and that one is kind of perpetually the center of all major activity. And manifestations of centrality can include referential thinking or delusions of reference and paranoia. And so as an example, I think like the presence of others in a restaurant might be only understood as something in reference to oneself, and the possibility that other people might be in this restaurant for other reasons, like that they enjoy that restaurant or they're there to meet family or things like that, is just impossible for someone to imagine. And so these ideations can quickly transform a person's surroundings into hostile or threatening environments that are full of vulnerability and potential danger. And in turn, this really negatively impacts a person's social relationships and their ability to successfully interact with the wider world. And it's further suggested that centrality is also related to and sort of thought to influence symptoms and skill deficits. So, for instance, persecutory delusions or referential delusions could reflect an attempt to explain the experience of being alone at the center of the world, or asociality and anhedonia might develop as the world becomes completely incomprehensible and other people stop being experienced as having their own unique purposes and interests. And then further, as others' uniqueness becomes more invisible, intersubjectivity and sustaining meaningful relationships is also compromised. And finally, centrality can really alter how one is able to understand and respond adequately to their own suffering. And so we see that there is really this like huge impact that centrality has on people's lives and their ability to navigate their life in a way that is meaningful to them or comprehensible to them. So the question here is really, how does all of this fit into the integrated model of metacognition? So now that we have like a little bit of a brief background on this idea of centrality, like what does this have to do with the work that all of us are passionate about? And you may have already noticed that through some of these descriptions that I've talked about, that the concept of centrality sounds fairly similar to what we might best recognize as a lack of decentration. And as we know, decentration involves how a person makes sense of their place in their community, and in particular, whether they can see that community as an interactive collective of people with different perspectives and histories and goals and possibilities. And although the idea of decentration was not explicitly based on this construct of centrality, it seems as though the lowest end of that scale really offers a way to describe and measure Grivois' idea of centrality and the subjective experience of being the center of all activity.
So, as Kelsey already kind of alluded to, one of the most tricky aspects of measuring subjective recovery and related concepts in my mind is, how do we measure this? How do we assess whether someone has an experience of subjective recovery or not? And I think the MASA is one really great technique or tool that we have to try to measure some of these more subjective experiences. And because we're conceptualizing centrality as a lack of decentration, naturally the decentration scale is going to allow us to really assess that experience and kind of measure it and get a better idea of what's going on. So we are all pretty familiar with the MASA here, I'm guessing. So we have self-reflectivity, understanding the mind of the other, decentration, and mastery. And of course, we're focusing on decentration for this presentation. So different levels of decentration as measured by the MASA can allow us to do a couple different things. One is they kind of let us observe recovery as it unfolds. So as people kind of progress from this state of centrality to decentration, we can measure that and kind of watch that happen with the decentration scale. And it also provides us with these discrete stages, so to speak, of decentration that we can then kind of target more directly in psychotherapy. Next slide, please, Kelsey.
There we go.
Thank you. So just to really dig into the decentration scale, because that's going to kind of inform a lot of what we talk about later in the presentation, we're going to talk about each level and kind of what it looks like. We're going to give like a super brief example and then try to connect it to some kind of functioning and what we might observe in a person whose maybe capacities at this level. So D0 is going to be the lowest level of decentration. So conceptually, I would say that D0 most aligns with the experience of centrality. So if you're functioning at D0 or you're working with someone who's functioning at D0, it's really going to include the experience of the self as at the center of all noteworthy activity. So as Kelsey was describing centrality, she was describing D0, I think. So really events are cannot be interpreted as unrelated to the self. So a really quick and easy example would be something along the lines of someone saying, the security guard that's here in the lobby, he's here because he knows my history and he's trying to put me in jail, right? So there's that lack of understanding or acknowledgement that maybe the security guard is there to protect people or prevent theft or whatever the security guard is actually there for. And then some maybe like symptoms or deficits that you might notice are going to be things like persecutory delusions. And those are going to be at a level that really impact the person's ability to engage in the world, right? So they may have a lack of relationships with other people. They might not be able to like maintain a job because their experience of centrality is so centered in their life that it is really impacting multiple levels of functioning. Next slide. So D1 is going to be just one step up from D0. So, and perhaps I should have started at this, but decentration is technically a 4-layer scale. So we have D0, D1, D2, and D3. So keep that in mind as we're kind of progressing through these and sharing the examples. So D1 is where people kind of start to recognize that events are occurring without reference to them. So people may be able to see that other people in their life do things or say things or think things that are not related to them. So an example would be being able to think about the fact that maybe your mother cared a lot about the neighbor's children because she was a caring person. So kind of just that first step up with being able to recognize and see that other people have thoughts and behaviors that are unrelated to the self. Still, that might come with some suspiciousness of other people, right? Which may lead to more difficulties in relationships, some unusual beliefs. Some referential delusions may still be present, but they're unlikely to be very fixed, right? And when I say that, I just mean that maybe as you engage in dialogue with these people, they're able to kind of say, maybe you're right. Like maybe the security guard isn't there just because of me, or maybe I can identify a thought in another person that's different from me or separate from my experience. And at D2, I like to think of D2 as the level where kind of validity comes into play. So not only can you recognize that a particular event or experience can be seen from multiple perspectives, but those perspectives are also valid, right? So you're kind of able to acknowledge, like, yes, someone has a different understanding of the situation than I do, and their perspective is valid as well. So again, at this level, people can see that others have valid ways of viewing an event that differs from their own perspective. So an example of this might be someone saying, my cousin noticed things in my father that I tended to ignore, while I could see things she was blind to. We were both right. And as we kind of increase up this scale, so as someone becomes more decentered in their life, some symptoms are also going to decrease, right? So at D2, maybe someone has some mistrust or mild suspiciousness, but this can kind of be challenged or thought about a little bit differently. And it probably doesn't have as profound of an impact on their day-to-day functioning. So if someone's at a D2, they probably have some relationships in their life that they're able to maintain and work through, right? They can probably understand the people that they connect with and interact with on a little bit higher level. So yeah, that's D2. And then our highest level is going to be D3. So if you think about a continuum, right? And centrality is on one side and the full experience of decentration is on the other. We're now all the way at that fully decentered side of the continuum. So this is where things, not that they get complicated, but this is where someone has an understanding of events, and events that occur in life are the result of complex emotional, cognitive, social, and environmental factors. And all those things might vary based on who's involved or who's playing a role in some of these things. So at this level, people can probably perceive their larger community as involving a lot of other people with unique thoughts, emotions, relationships with other people. And these relationships aren't necessarily organized by a central theme or a single thing that is a reason why everyone is there. So this example is a little bit wordy just because this is kind of a complex level of functioning, so statement, but something along the lines of, I think my father reacted to my disobedience negatively because he faced abuse in his own childhood and his parents did not teach him how to be a good parent. He also grew up in a family and community that held a lot of racist beliefs, which contributed to his hard upbringing, right? So in this example, the person is able to really think about the father as having his own life, his own unique set of experiences and things that happen in his life that impacts the parenting style, essentially. So there's this complex understanding of another individual and kind of what's going on. At this highest level of decentration, individuals are likely to be involved in community events and organizations. They can maintain unique and adaptive relationships with friends and family, and they are able to kind of understand that nuance in those interactions with other people.
Alrighty, so how do we use all of this information to kind of target centrality within our psychotherapy or within our work with people? We think that through the lens of the integrated model of metacognition, decentration has not necessarily traditionally been a target of psychotherapy, but has been perceived more as like developing through improvements in other domains of metacognition that are more often the targets of interventions in psychotherapy, like self-reflectivity, understanding the mind of the other, and mastery. And decentration has really been seen as an important piece of conceptualization of clients. But here we're proposing that the experience of centrality or low decentration actually can be a target in psychotherapy. And we also suggest that the gains in decentration that people can see throughout engagement in therapy can have a really important impact on recovery, specifically with regard to people developing a subjective experience that enables them to make meaning of their life and their suffering, as well as building their identities as full agents in their life and finding their place as members of the community at large. Okay, so now we'll get into kind of really talking about this like 3-phase approach to therapy that we think is really helpful in like targeting centrality within psychotherapy. So with all of this in mind, we really believe that each level of decentration can be used to identify a level of centrality that can be addressed differently within therapy, such that like different processes may be applied depending on what a given patient's functioning is assessed to be in this domain of decentration. And so we'll spend some time illustrating this through proposing 3 separate phases of therapy and exploring how things might be approached differently with patients at each level of decentration and how these strategies might promote movement through these phases. So we'll start with our first proposed phase, which we view as the patient inviting the therapist to join their centrality. So this would look like, this would be like a patient who is rated at a D0 or maybe even a D like 0.5, but is incapable of the full activities required for ratings of D1, D2, or D3. And someone in this phase would have the general sense of themselves as the focal point of the world around them and view themselves as the center of all meaningful activity. And the idea here is that as rapport begins to develop and decentration starts to slowly increase, the patient may start to invite the therapist to join their world or their centrality. Essentially, the patient offers a door with which the therapist is able to enter into the patient's experience with them, subsequently giving the 2 of them a chance to understand this experience together. And one way this seems to commonly emerge is through finding non-threatening, straightforward ways to relate to one another or to foster connection. For example, a shared hobby or an interest in food. And as such, the therapy relationship, while it's always a key component of psychotherapy, I think really becomes particularly important during this initial phase. And for successful movement through this phase, we think that it seems really important that the therapist approaches sessions with curiosity and the belief that the experience of centrality can be understood as an aspect of human experience rather than this sort of other symptom or something that's outside of the realm of human experience. And that this also includes being able to tolerate and navigate the confusion that is likely going to emerge from this. And so in fewer words, I think we just want to create an environment where patients can feel comfortable enough to invite us or the therapist into their world. And in turn, we have to be willing to be vulnerable enough to join the patient and also be known by them as well. All right. So while all the merit elements continue to be present in every session, we kind of have identified 2 metacognitive tasks. And each phase will follow kind of this structure where we identify like what metacognitive tasks we find to be the most prevalent or the most relevant, I guess, in each phase. So for this one, we identified 2 different metacognitive tasks that appear to be vital pieces to highlight in this initial phase. And the first is attention to the patient's agenda throughout the session. And so as we know, agendas manifest as the patient's motives, wishes, desires, plans, or purposes that are brought into the session. And agendas can be different session to session. They may change as the session progresses, or they may even be contradictory, or there might be multiple present at the same time. And the primary purpose of this element is really to promote the experience of oneself as an active agent in treatment. And so by promoting the patient to be an active participant in session and encouraging them to reflect on their own wants within psychotherapy, that's how we can get this sort of metaphorical door to their experience of centrality to open, and we can then have that as a topic of reflection that's on the table. And the second key metacognitive task in this phase is establishing the therapist as a partner in dialogue, which involves the therapist sharing the contents of their mind in a way that elicits collaborative thought and reflection about those thoughts. And so this element really serves two important purposes. The first is promoting stimulation of understanding the mind of the other, and then exploring one's own mind as it reacts to our or the therapist's disclosures. And so I think really emphasizing this element in this phase of therapy allows for a therapeutic connection to emerge. And as agency and connection develop through focusing on these two elements, this sort of sets the foundation for the patient to invite us to join their centrality by connecting over shared aspects of themselves or of one another. So it's important to consider some things that also may pose crucial barriers to successful movement through this phase. And first, it's important for therapists to be aware of the potential threat that decentration may pose to the patient. So when someone's in this like space of significant fragmentation and centrality, attempts by the therapist to know the patient or make themselves known by the patient can be perceived as pretty dangerous or overwhelming or like incomprehensible. And so given this, we should really try to avoid directly confronting or attempting to correct the patient's view that they're the center of all meaningful activity. Instead, it seems more helpful to really intentionally choose interventions that foster meaning making and joint reflection that will help gradually lead the patient to higher levels of decentration. And so to try to bring these ideas to life, I'll share a case example of a former patient of mine as we worked together through this phase. And so this individual is diagnosed with schizophrenia, characterized by pretty significant negative symptoms. And he really tended to view me as someone to keep at a distance. And I started to recognize that he may be pretty unsure about like how, or even if it was safe to connect with another person. And because of this, we really had like a series of chaotic and confusing conversations. But through this, I really tried to remain curious about this confusion and reflect on his agenda to keep me away or keep me at a distance. And I really tried to focus on sharing my mind with him, often sharing that like I was also finding myself confused and we could kind of join in that confusion together. And so through focusing on these interventions, we ended up having a particularly like salient session that seemed to really shift the momentum of our work together. And during this session in particular, we discovered that we were both Pisces, the astrological sign. And although neither of us were really inclined toward an interest in astrology or like knew anything about it really or what that meant necessarily, it was still a way for us to like relate to one another and connect with one another. And we began to think of ourselves as like two fish in the same ocean. Because if you're also not very interested in astrology, the symbol for Pisces is fish. And so we thought of ourselves as these two fish in the same ocean, but that he was really unsure if like he could about what kind of fish I was. Like, was I a bad fish, like a barracuda that was hunting after him, trying to get him? or was I a good fish, like someone that he could befriend or trust? And it seemed that like finding this thing that we had in common and really could connect on allowed me permission to enter into his world, or I guess his ocean of centrality. And through this, we were really better able to reflect on our therapeutic relationship. And he began like viewing me as another person in his world that might have experiences outside of him. Which kind of made room for him to move from D0 toward D1.
Yeah, so we kind of think of phase 2 as the start of like acknowledging other people as different from oneself. And that can be different in that they have different thoughts and desires and wants in their lives. But this is really going to include people functioning at D1 and kind of transitioning towards D2. So again, in this stage, patients or the people you're working with begin to acknowledge that others exist as kind of distinctly different from oneself. And they may start to recognize that other people, including the therapist, have different thoughts, opinions, desires, have different things they go and do, different hobbies, different favorite foods. So really this differentiation process happens or starts to occur where the patient is able to view other people as distinctly different. I think it's kind of important to think about the fact that this is probably going to start with relatively safe material. And kind of just building off of what Kelsey talked about, the experience of decentration can be pretty threatening when you've been kind of in this space of centrality for a period of time. So beginning with relatively safe material is probably pretty vital here, I would say. So safe material might include things like hobbies, right? So like, what are your hobbies and how are those different from what the patient might do or what the patient's hobbies might be like? But as this experience of decentration kind of builds through phase 2, the patient is likely going to be able to tolerate like increasingly complex ideas about how the therapist and the patient are different, and how they hold different roles in the world and how they think about things really differently. And I think that creates a really rich space for reflection and the ability to kind of think about these things a little bit differently. Next slide, please. So we only have one metacognitive task for this phase, but I think it's a really important one. And that's going to be really focusing in on eliciting narrative episodes. So as we kind of know, narrative episodes kind of emerge as stories from patients' lives that provide an increasingly cohesive sense of the patient, who they are, what their life has been like over time. And I think by focusing on this element, we're able to place attention and reflection on how the patient views themselves and other people within their wider life and community. And it allows those differences to become apparent. And then at that point, the differences are up for reflection, up for joint reflection. So as we learn about various characters in someone's life and what their role is or what past interactions have been like for these people, you can start to think about with the patient, like, how are these people different from you? What are their thoughts? What do they think in this moment? And I think this is really tied to understanding the mind of the other. So of course, each subscale is going to be intertwined with all the other ones, but I feel like understanding the mind of the other really plays an important role here. So eliciting narrative episodes, it kind of plays maybe like a twofold role here. So it's going to support the therapist in viewing the patient as a unique and complex being in the world, right? Someone who has unique experiences and is doing things, even if maybe it doesn't always seem like it. And like I kind of mentioned earlier, it's going to also simultaneously place attention on how the patient views themselves and significant other people in their life. So by gaining more narrative episodes and learning about those narratives that kind of come forth, the therapist kind of has this opportunity to share their own distinct experiences, thoughts, emotions that can also be jointly reflected on to promote this sense of awareness that the therapist is a distinct person, right? So if phase one is all about having the patient invite you into their world, into their space of centrality, phase two becomes about trying to help the patient see that you are a distinct individual in their world. So barriers, you guys are going to see a theme with the barriers. I think they're all pretty similar for each level. But the barrier here is really going to be acknowledging differences that are too threatening, too big, too important, too quickly. So think about something like hobbies, right? Like hobbies aren't too threatening. Everyone has hobbies. Everyone has a different hobby. So that could be a great place to start. A more tricky place to start is going to be like political views, right? Or like religious views. I work with veterans mostly, and political and religious views are probably not the first thing I would bring up to try to like establish myself as a distinct person in the therapy room. But something a little bit easier and straightforward, maybe I would do. So case example, this is a veteran I worked with back at my time at the Indianapolis VA. He was also diagnosed with schizophrenia. He had a lot of trouble with trust, I would say, and not being too sure of who he could trust, including myself. So he kind of oscillated between feeling like he could trust me, feeling like he could really talk to me and share things with me, to like taking a big step back and saying like, well, like, wait a minute, who even are you? Can I trust you? I don't know anything about you. He often wondered if I was a witch that was kind of placed in his life to like set him off track, or like distract him from what was important in his life. So there were a lot of conversations about that. But I think in summary, or way to put this a little bit more clearly, is he was really uncertain about what I was doing. He wasn't sure if I was there to make his life more difficult or maybe help in some way. But as we talked to each other and got to know each other a little bit, he shared a decent amount of narrative episodes. He talked about like pretty extensive childhood abuse that was really important in how he thought about other people and who he could trust. But he also talked about like really, really straightforward, like I went to the grocery store the other day narrative, and like, here are the people I came across, and here's what I thought about them, and here's what I think they were thinking about me. So he would always walk to this one grocery store, and he would have these just like odd interactions with people, you know, like questioning what they were doing there, questioning why they were there. But the grocery store narratives allowed us to kind of have discussions about other people and what they may be doing in the grocery store, right? Like, why do people go to the grocery store? How are they connected to you? How are they not connected to you? And eventually we had a conversation about like our favorite foods, right? Because he went to the grocery store and he was like, I bought my favorite food. I don't remember what it was at this point, but he asked me about my own favorite food and like what things did I eat. So in that moment, I made the decision to disclose to him that I don't eat animal products whenever possible. And he was shocked. He was taken aback. He was like, "That's crazy. How do you not eat meat? Like, what are you doing?" And in passing, it was such a small moment that it didn't even like click with me as anything important happening in that moment. But a couple weeks went by, right? We did our usual stuff in session, and he came back to me one week and he was like, "Hey, I tried a meat substitute and it wasn't awful." He said it kind of in like a funny way, like, haha, but he said he tried it because he saw it in the grocery store, right? He was at the grocery store, seeing a bunch of people he didn't know. He saw a meat alternative and he was like, "Courtney eats stuff like this." And he had like a thought about me, a distinct thought that I'm different than him. I do this in my free time. And then he tried it and he said it wasn't awful, which is something, I guess. But regardless, that like first little inkling of like, my therapist is different than me, she does different things. And as we kind of continued, and I was able to kind of scaffold his ability to acknowledge that I'm different from him, other people in his life are different from him, we we tackled some really like complicated ideas and differences, I would say. He was a very religious person and I am less religious, so we talked about that distinction and how that impacts how we think about the world, how we think about his problems differently. um and at that point he was certainly transitioning through D1. I'm not sure if he hit D2 solidly. I'm not sure if he ever like viewed me as having valid thoughts that were different than him, but regardless, he was kind of progressing through D1 towards D2 during our work together.
All right. And then moving into our third and final phase, which we recognize as, or we acknowledge as recognizing an alternative perspectives. So in this phase, a patient is really able to successfully perform the activities required for D2 and is beginning to transition to D3. And so someone in this phase is really able to recognize that other people perceive or interpret events differently from them and acknowledge that these differing perspectives are valid. And then as they move through this phase, they're beginning to develop the ability to increasingly understand that other people have complex lives that are made up of a lot of different factors, including emotional, social, and environmental factors. And they may start viewing the world as more of a collection of unique individuals who have unique relationships with one another, and that there's no like real central organizing theme to that. And I think notably as a function of gaining awareness of others' lives and the challenges of the world at large, patients may experience increased distress in this phase, kind of namely surrounding interpersonal and intersubjective events. And I think this challenges a certain comfort that might have been acquired in the experience of centrality. And so kind of with decentration comes the uncertainty of a world that extends beyond ourselves. So the metacognitive, oh, let me actually move this forward. Oh, I already did. Okay. Sorry. So the metacognitive task that sort of appears to be a key agent of change in phase 3 is defining the psychological problem. And as most of us know, this element involves the therapist and the patient finding a mutually agreed upon plausible psychological problem on which to reflect. And I think of note here is that this element occurs within the process of all the other metacognitive tasks we've discussed so far, and is not focused on identifying a specific symptom or diagnosis or engaging in a specific kind of treatment, but rather as the patient develops an agentic approach to therapy, and they engage in reflective dialogue with the therapist, and related in all of this kind of related to exploring a variety of narrative episodes. And then they're able to reflect on the reactions to the therapist's mind, which altogether, this provides a platform for confronting pain and distress. And so I think a special emphasis on the psychological problem in this phase really requires the therapist to be attentive to complex problems that may emerge as the result of a person's broadening perspectives that they are acquiring with greater levels of decentration, and really encourages the patient to question and reflect upon like broader life challenges, like interpersonal difficulties, trouble with connection, feeling excluded or isolated, experiencing stigma, and so on. So much like the other two phases, there are also important barriers to consider that might pose challenges in this phase. And the first is the possibility that with increased awareness of the world and one's place within it, also comes increased pain and loss. And so as a person begins to sort of emerge out of centrality, the comfort and protection that's often rendered from this more fragmented state is lost. And so due to this increase in suffering and painful realizations, there's also an increased chance of ruptures to occur within the relationship. And so we should really like take care to be attentive and diligent with the therapy relationship, so we can actively repair ruptures when they happen, and think about these ruptures with the patient, and then continue to provide sort of this solid foundation or relationship for dialogue and reflection. And I think finally, the nonlinear nature of metacognitive gains has been established, and this nonlinear nature can also pose a barrier in this stage. So I think that like sometimes when we notice that people are reaching these higher levels, we might tend to take those things for granted, and we want to make sure that we're not doing that, and that we continue to sort of evaluate these fluctuations that are inevitable and likely to come between and within sessions, and make sure that we're like adapting adequately to them with our interventions, and really making sure that we're meeting the patient where they're at in this sort of experience of increasing awareness and then subsequent pain and loss, and the sort of nonlinear nature of that. And so to illustrate this phase, we'll offer a case example. And I think that I meant to start with this and like explain sort of that this whole talk sort of came from a paper that Courtney and I worked on with Paul and Hugo Fulpin. And this case example is an example of a patient that Hugo worked with during a period of hospitalization. So I'm going to try my best to do my due diligence here and to do it justice. But I don't know like additional details or anything like that if you were to have questions. But I think so in this example, through Hugo and this patient's work together, they were able to reflect on psychic functioning of other patients in the hospital. And I think that they were able to then identify and recognize some of the patient's own traits, and within the other people that were on the unit. And they found a way to access this like fictional representation of herself in the place of other patients. And doing this really allowed for them to begin to like have some shared reflection on her own situation. And through this, she was able to gradually detach herself from identification as a patient and really access narrative episodes prior to her illness and hospitalization, which included a pretty profound difficulty connecting with other people and understanding other people. And with elaboration of these narratives and really exploring through these things, and the sort of increased levels of decentration that she was experiencing, the two of them were able to identify this like prominent psychological problem throughout her life of the experience of isolation and a real lack of community or a lack of belonging. And this realization, it seems, quickly became like a source of suffering for the client and was really painful for her to face. And they did notice this sort of regression in her capacity for decentration, where the patient really struggled to access anything other than her immediate pain for periods of time. But as Hugo remained curious and vulnerable within the sessions and really attended closely to the therapy relationship and tailored his interventions to match her current level of functioning, and just continued to provide a space for the patient to tolerate her own pain, he started to notice like moments of clarity and reflection emerging for increasingly longer periods. And at these points, the two of them were really able to reflect more deeply on a complex and integrated understanding of herself and other people, and the world around her, where there was various factors of those emotional, social, and environmental factors that became important, and that multiple alternative perspectives became available to her. And so this sort of represented her movement through D2 toward D3, but that this was not like a linear progression, that there were lots of times where she seemed to kind of dip in her metacognitive gains, and then for periods of time, her decentration would increase, and then there may seem to be another dip in her ability for decentration. And so this was really a pretty nonlinear course from D2 to D3. Before we move on to the sort of conclusions and discussing like future work, I wanted to maybe pause just for questions or anything that might be helpful for us to think about now. If none, we can keep going, but I just wanted to offer that space. Okay, well, we can move forward. But one thing that I did want to mention was that you probably, or maybe not, I don't know, but like you might have noticed that the key metacognitive tasks that we identified for each phase kind of comprised all four of the content elements of merit. And we felt like those were sort of the key things to focus in on these phases, with the understanding that like all of this is still happening within the context of exploring the therapy relationship, really paying attention to progress through therapy, and attention to change over time, and also like making sure to tailor the interventions based on the metacognitive level that a person is at. So I just wanted to make clear that that was an assumption of all of this, that those things are still continuing to happen, but that the key sort of content elements for each phase we felt like were the important ones to focus on.
Yeah, so in conclusion, centrality is a key component of the psychopathology of psychosis, can certainly be understood by any of us, I think. I like to think of the kind of classic example of walking into a room and like everyone stops talking and you're like, well, they were definitely talking about me. Like that is an experience of centrality that I think we can all relate to, and kind of use that understanding to further connect with these people and like understand their experience as well. So we propose 3 phases of centrality that a person may experience or kind of move through as they develop kind of increased decentration. So inviting the therapist into the experience of centrality, recognizing the therapist as different or with different perspectives, and then recognizing like a broader range of alternative perspectives over time. So I think kind of naturally in some ways, as centrality quote unquote improves or as decentration increases, I think individuals with psychosis and potentially like a range of different disorders may start to discover a deeper sense of their place in their community, their belonging in part of a community. And that can then offer opportunities for improved interpersonal interaction. It can kind of promote the sense of purpose. And it kind of enrich one's understanding of possibilities that might be happening, right? Possibilities they have for a meaningful life, right? Like relationships that could develop. And Kelsey already talked about this a good bit, so I won't harp on it too much here, but it's really important to remember that changes in decentration and on all of the metacognitive scales are likely not completely linear and will kind of fluctuate session to session or change a little bit, right? One day someone might be at a D2, the next day they're at a D1. So that changes session to session, and that's just something to kind of keep in mind. And then just a few thoughts about future directions. This is all like very theoretical, right? This was me and Kelsey and Paul and Hugo like sitting in a Zoom, like talking about things, kind of drawing on our own clinical experience, thinking about how we understand the integrated model of metacognition to kind of come up with this framework or these three phases. So obviously we need empirical studies, kind of testing and exploring some of these ideas, kind of just like further establishing this proposed framework as a method for maybe targeting centrality. Then, of course, some additional research on the development of centrality and decentration across the course of psychosis. And I don't think Marina is here, but Marina has this really great paper from back in 2013 that found that individuals with higher decentration had a stronger sense of subjective recovery. I thought that was a pretty cool finding and kind of gives us a little bit of support in our idea that thinking about decentration and trying to improve that a bit can have some really great outcomes for subjective recovery. So maybe expanding that, thinking about that a little bit more. And then a final thought, because decentration is so connected to community, right? We really think it would be cool to explore this framework in group therapy settings, just given that level of community and connection that sometimes develops from group settings. And Merit G, which is a group therapy that is merit-oriented based on merit, I think that could be a really rich domain to kind of start that process and think about that a little bit more. So yeah, I think these ideas are really in their infancy and there's a lot more to do and a lot more to think about. And on that note, I think we'll open it up for questions, comments, concerns, anything you guys want to share.
Hey, do you hear me? Yeah, okay, nice. Thank you for your presentation, both of you. I have this thought that maybe a peer helper, like a professional peer helper, uh, that is trained to merit. I think that that would be an interesting person to I mean. I think that a peer helper for the maybe for the phase 1, like sharing his experience of his centrality and how he how I lived it. I think that would be a nice thing to think about. But I think that in merit group, it's also like peer helping, but it's not professional, but still it's the same process, I think.
Yeah, I think that's a great thought. Here at the VA, we have what we call peer support specialists, and they are individuals with lived experience of mental illness. And in my clinic, we're lucky to have a really great peer support specialist. And I find that peers can often just like say things that I can't, or just like approach things a little bit differently. And I'm wondering, as you kind of said that, if it's easier to invite someone who maybe also has lived experience into that like phase or like position of centrality than it would be to invite like me or Kelsey in there with the patient. Yeah, that's a really, really great thought. Kelsey, do you have any additional about that?
No, I mean, I had similar thoughts that I really liked that idea. And we here at Sandra Eskenazi, we're in the process of like hiring a lot of peers, which has been really great. And we've been utilizing their expertise in lots of different ways. But I think that the idea of like, in particular, someone who has like lived experience of psychosis and really might have like their own like unique experience with centrality, like really could be sort of a vessel for like trying to understand what this experience is like, and they're kind of uniquely qualified to like understand this with the person. And I think that seems like a really good thought.
I have first just a comment that this was really helpful for me to like think through decentration, centrality with my work, because it's been, as a merit therapist, it's been a little harder at times to kind of know concretely like how to target this. So it was really helpful. I liked the future directions you had. I've been thinking a lot about kind of the developmental models of like metacognition and such, and just curious if you have any just preliminary thoughts. I know some of these are in early stages of like any thoughts on what contributes to decentration or centrality, low decentration with those developmental things. I just find that stuff really interesting. Been thinking about that more lately.
Yeah, I will start by saying I don't know. But I have also been thinking about like the natural development of decentration or of metacognition in general. And I've kind of thought about the idea that like an early adulthood, right? Like as people are becoming true individuals, right? And like that's all happening, but also this sense of like ego centrality is maybe decreasing as well. Like, does that mean then that the experience of decentration increases in early adulthood, like naturally as we progress as individuals? Kind of like similar thoughts about understanding the mind of the other. Like, as we gain more experience interacting with people and become less self-centered, for lack of a better way to put it, like naturally through development, like does that impact some of those things? I don't know, but just I've also kind of been thinking about that a little bit.
Yeah, and obviously like when you're developing psychosis, it's usually kind of around that age when you naturally become kind of less self-centered, I guess, like in early adulthood. And so I guess psychosis like may disrupt that. That is interesting.
Yeah, and I think there's maybe like some initial research on this from Kyle Miner's lab. I'm not sure about the details though, but just on like the developmental path of metacognition and kind of what happens over the lifespan.
I think too, I know on the heels of our like merit trainings that we did over here, I know Bethany mentioned about like the work with the clinical high risk population and that like youth, there is some evidence that like younger people like in late adolescence, early adulthood do just like as a function of being younger do have like deficits in decentration and understanding the mind of the other just as like a function of being young, but that also there seems to be a unique sort of deficit for people who are maybe who have psychosis or who are like clinically high risk for that as well. So it does seem like there's some sort of developmental component. And I'm remembering reading like as we were writing this and like thinking about these things, I think it may have been like Hugo's initial paper about this from 2022, where there's like some idea that this could be like, well, for lack of a better like metaphor, I guess, like a chicken or the egg situation where like that the idea that people who maybe have not developed psychosis yet, but are like more in that prodromal phase of psychosis, maybe we might start to notice these experiences of centrality happening before someone actually starts to experience psychosis. And so I think that is also an interesting thing to consider too, of like, does this sense of being sort of like losing your connection to the larger community and like losing your where you fit in or where you like your identity within the larger the world at large, like does this seem to like come before like development of psychosis?
Yeah, an interesting thought. And just maybe like one additional thought to that is some of my dissertation research was on a schizotypy population, and it was actually about like referential thinking in eye gaze. So when people with higher levels of schizotypy look at other individuals with like ambiguous eye gazes, so like they could be looking at you, they could not be looking at you, they're significantly more likely to say that people are looking at them. And this isn't like a non-clinical population. These are just folks at higher risk of developing a psychotic disorder. So even at that point, there seems to be some support for the idea that you're starting to like view yourself at the center of some of the things going on around you, which I found really interesting.
So my sense from listening to the kind of proposal for how to proceed with this is that it doesn't sound as though you're arguing for like an adaptation of merit more so than that this uh, is a phenomenon that can be addressed through the existing framework. Do you think that's right, or do you think that there are things that maybe we should keep in mind that are a little bit different than just our kind of sort of usual way of training or thinking about the practice framework?
That's a good question. I know that we definitely try to stay within the existing framework, right? And like, whereas there are specific like elements, right, like stimulating self-reflectivity and understanding the mind of the other and mastery, right? Like those three subscales are directly targeted. And I think for a long time we've thought that like by proxy, like decentration also increases. I don't know if I feel confident enough to say that like there's an adaptation there, but maybe I think it would be really cool if we kind of continue down this path in some ways and thought a little bit more about if we need to think more about specific interventions to increase decentration. Yeah, I don't know. Kelsey, what do you think about that?
Yeah, no, I mean, I have similar thoughts to you. I don't think that we approached writing this as like suggesting that there needs to be an adaptation or anything like that. But I do think that like there are some interesting things to think about, like what you mentioned, like are there specific interventions, or maybe like when we're training people to like when they're maybe working with people who have pretty low decentration, which is I think pretty common, like maybe thinking through more of talking about this in the way of like here are maybe the elements within these different phases, like where you're rating somebody, here are the elements that you might want to like focus on a little bit more. I don't know that we necessarily do a lot of that when we're training folks. And I guess the only other thought that I have is that like within the elements we don't have like a stimulating decentration element like we do within those superordinate elements. And so like I guess that might be the only other thing that we might consider as we think more about this stuff, is just like, is there a need for that, and to like kind of pose decentration as something that should be targeted during a therapy session and should be present, or is that something that's just kind of like already happening through the stimulation of the other domains as well?
Yeah, I think I agree with like really trying to like figure that out and distinguish between those two ideas. This makes me think of a veteran I'm working with currently, and he doesn't experience like many hallucinations or like true delusions or anything, but he certainly like experiences centrality. Like I would say that is his number one kind of challenge that he's up against, is the belief that like people are constantly judging him and constantly thinking about him and constantly like making comments about him. And this paper has helped me think a lot about like, how do I help? Like, what do I do here? How do I help this person? And I would have to think about it a little bit more, but I'm not sure if I'm doing like the traditional merit stuff, or if I'm doing something that's like a little bit extra or a little bit different based on what we thought about in this paper. But yeah, I definitely think that like a lack of decentration is like a distinct challenge for people that they are kind of up against.
I think a thought that came to my mind kind of related to that, and just sort of thinking about like, how do we actually stimulate decentration and intervene upon it, since it hasn't really been something that we put a ton of focus on previously. But one of the criticisms of the decentration scale is just that it's so small. I mean, there's only 4 items if you count D0. And so I guess I'm wondering, as you guys have given this more thought and are thinking about like how to actually help promote it, like, do we think that there would be additional items to the scale? Like, because especially from like 1 to 2 is like a giant leap, right? And like 2 to 3 is they're huge jumps in terms of ability to like think about the world in complex ways. And so I wonder if like, if as we're sort of fleshing this piece out, would we need to like find some kind of like steps in between to actually help people kind of scaffold these things?
Yeah, I think that's a great thought. Just through my own experience, like leading some of the Mass A scoring groups, like especially for decentration, we talk about the sense that like maybe this person is like a 1.25 or like a 1.75. So like not quite at one of those half a point marks. So they're not a 1, but they're not a 1.5. We think they like fall somewhere in the middle. And then we kind of just have to make a judgment call for like, what do we give this person for decentration? But I think that speaks to the fact that there maybe is some missing steps, or I don't know, like missing stuff that someone progresses through from D1 to D2. Yeah, I definitely agree that it's like feels like a large jump from D1 to D2 and even D2 to D3. Yeah. I also, sorry, just one more follow-up thought. I think that like the other scales, other subscales feel so sensitive to different things. And decentration maybe doesn't always feel sensitive to picking up to some of those things. So I wonder, even in like when we're looking for change in metacognition, like, are we sometimes not even picking up on changes in decentration because our scale has those bigger jumps from D1 to D2 and whatnot?
Yeah, I think that's a good point. When I think of like, I often kind of think of decentration as like, I think I mentioned this earlier, but as like the other things, we see the other like domains develop first and then decentration kind of follows along. But is that actually like the case? Is it more that there are more increases in decentration that, like you're saying, we're just not picking up on, or we don't have like the language for, or the uh like anchor for at this point? And like, would we be able to see different kinds of gains or gains sooner if we had a different, like more ways of measuring that?
I had a question for you guys. It's a little bit different than what we've been discussing. I had to send it over to Bethany to make sure it made some sense. um, but so I work with quite a few folks that do have some personality components that kind of complicate their picture of psychosis, and particularly when some of the narcissism comes into play, it does seem like centrality is definitely a part of that experience. I'm thinking of one person in particular who comes to session with, a host of external rationale for the problems in his life. Like, it's this woman's fault, or it's the COVID vaccine, or it's this procedure I had, um, and it kind of goes on and on. And sometimes like his belief in those rationale will waver a little bit, and he can start to kind of invite himself to take some personal responsibility into his lack of connection, or the pain or the suffering that he's experiencing. But then I think when that gets overwhelming, it's right back up to the external stuff. So I was wondering a little bit, kind of like, about targeting that centrality with some of our folks that do have these personality components that does seem to exacerbate that centrality, and what some of your thoughts might be.
I'm not being quiet because this was a bad question. I think it was a really good question. I'm just thinking about what are my thoughts.
I'm on a similar page there. I think, and this might just be in my own clinical work, but I find that personality trait situations just like complicate everything like so much for me. Because it feels different in a lot of ways, and maybe it's not, but I'm thinking of a guy that I work with who also has some like narcissistic traits and like just like some grandiosity floating around. And when I try some of these things with him that we talked about, they just don't land the same. So I don't know if that speaks to like a real difference there, or maybe I need to change my approach a little bit, but it's an excellent question. I don't have any clearly defined thoughts, but yeah, I don't know. Kelsey, have you had any additional thoughts in the time?
I do find like these are not probably well-formed thoughts, but I do find it interesting. And I don't know if this is like a function of personality pathology or not, but I think that like it is interesting to think about maybe these like centrality in this way of sort of this um, like external reasons why things are going wrong versus internal reasons why things are going wrong, or like internal attributions versus external attributions to like life problems and stuff like that. And that is really interesting to think about. And I have similar like just anecdotal stories, I suppose, of like I'm thinking of one client that I work with currently in particular who kind of has a lot of like narcissism and like I agree, Courtney and Andy, that it's like it feels like the interventions that often like seem to forge a connection or some sort of like ability to reflect on things with this individual just don't. It just seems like there's some sort of different kind of resistance to those interventions, and I don't know exactly what that is or if there's a different way to think about like how to intervene with individuals who have personality pathology. But I think that these are really interesting thoughts. I just don't have any well-formed thoughts about how to I don't know how to intervene more helpfully for those individuals.
I was
Open
going
to
to say,
people's
you asked
thoughts
that
too.
question because, oh, sorry.
Oh no, I was just calling for other people's thoughts. So you read my mind.
I was going to say, I'm glad that Andy asked that question because I was like at a high level explaining the Massey scales and merit elements to a psychiatry resident the other day. And as I was explaining decentration, his reaction was, oh, like narcissism. And so, and was kind of thinking about folks with NPD traits. And during the presentation, I was thinking about some folks that we work with who have more prominent personality pathology, as well as like in the veteran population. We work with a lot of folks with PTSD, and I think you see some similar concerns with centrality there of just like interpreting benign threats as being related to them in a way that can also like hinder decentration. So I don't have any well-formed thoughts either, but in terms of future directions, if we hone in on some interventions for decentration, I think those can be really helpful transdiagnostically.
Yeah, and I know there's been like some and anyone correct me if I'm just wrong here, but there's been maybe the most research in like a metacognitive model and mentalizing, of course, with borderline personality disorder. I don't know if it's expanded much to other personality disorders. But yeah, I'd be curious to just like review some information about how we typically use merit in personality disorders and if there are adaptations or changes that we make. I remember there being like a small section in the book, but I don't remember the details, of course.
I guess it makes me think a little bit of like a typical metacognitive profile of someone with or people like with borderline personality disorder, where like we tend to see a trend for like higher levels of S and O and then maybe like lower levels of mastery, where like they are able to reflect on these things, but they just don't know what to do with it or what to do about it. And like, I wonder if there's a similar sort of profile. I don't know, Andy, if your specific person you're thinking about, like prisons with more narcissistic personality traits or not, but and maybe you said that and I just missed it. But like it makes me wonder if there's like a common metacognitive profile for that group of folks where it's like maybe we see a unique like deficit in decentration with that group of people, and that would be interesting to kind of look into probably too. Not sure if any of those thoughts were actually helpful and working with the person that you're thinking of, but
No, that it is helpful. I think it is. It's a big can of worms to open. But it's encouraging. I think as we were all talking, I saw lots of heads nodding. I think this is a universal experience that we have, and it's challenging. But no, I appreciate hearing everyone's thoughts.
And hopefully this like line of thought and line of research kind of continues to progress, and we learn a little bit more about decentration and what it means and how we target it and all those good things.
well, I'm noticing the time that it is 11:30, so we can let all of you go, but thank you guys for all of your thoughts and all the discussion. I think it was really thought-provoking, so thanks everyone for coming. We will have our next webinar in November, first Monday in November. I can't remember exactly what date that is at this point in time, but hopefully we'll see everybody there.
Thank you,
Great
guys.
talk, guys. Thank you.